Does hormone therapy cause breast cancer? And what the evidence actually shows? If you are considering hormone therapy for menopause, there is probably one question sitting in the back of your mind. What about breast cancer? For more than 20 years, millions of women have been afraid of hormone therapy because of this concern. But here's what often gets lost in that conversation. Hormone therapy isn't one medication. Estrogen alone is different from estrogen plus a progestogen. Your age matters, when you start matters, how long you use matters, and your individual breast cancer risk matters. So today I want to walk you through what the evidence and the Menopause Society actually tells us. Much of this fear goes back to the Women's Health Initiative, or WHI. In 2002, early results from this very large study raised concerns about breast cancer and other health outcomes among women taking hormone therapy. The headlines were very frightening. Hormone use dropped dramatically. An entire generation of women and many healthcare providers became afraid of menopausal hormone therapy. But there was an important problem with the way that message was interpreted. The WHI wasn't testing one universal thing called hormone therapy. It studied different hormone regimens in different groups of women. And as researchers continue following these women, the picture became much more nuanced. Estrogen alone and estrogen plus progestogen are not the same. And this is one of the most important things I want women to understand. If you had a hysterectomy and you don't have a uterus, you may be able to take estrogen alone. If you still have a uterus, systemic estrogen generally needs to be combined with a progestogen to protect the lining of the uterus from endometrial cancer. Why does this matter? Because their breast cancer outcomes are different. In the WHI randomized trial, estrogen alone did not show the same breast cancer signal as estrogen combined with medroxyprogesterone acetate. Long-term follow-up actually found fewer breast cancer diagnoses and fewer breast cancer deaths in the estrogen alone group compared with placebo. That does not mean estrogen prevents breast cancer or that every woman should take estrogen. But it does challenge the common statement that estrogen causes breast cancer. That's simply too broad. But what about estrogen plus a progestogen? Here is where we need to be more careful. Combined estrogen-progestogen therapy has been associated with an increased risk of breast cancer with longer use. According to the Menopause Society, the increased risk generally becomes detectable after approximately 3 to 5 years of estrogen-progestogen therapy. And even here, the absolute risk for an individual woman may still be relatively small. This is why I don't like saying hormone therapy is either safe or dangerous. The better question is, what is this woman's baseline risk? What hormones are we considering and what benefit is she likely to receive? Does the type of progesterone matter? Probably, but this is an area where we need to distinguish strong evidence from promising observational evidence. The original WHI combination trial used conjugated equine estrogen plus medroxyprogesterone acetate, a synthetic progesterone. Today, many clinicians prescribe micronized progesterone, which is a chemically identical to progesterone produced by the women's body. Observational evidence suggests that breast cancer risk may be lower with micronized progesterone than with some synthetic progestins. But we don't have the same large, long-term randomized trial evidence from any modern combination. So I would not tell a woman micronized progesterone has no breast cancer risk. That's simply not true. We don't have enough evidence to make that promise. We have to put the risk in perspective. This is where conversations about hormone therapy often fail. Women hear the words increased risk without understanding how large their risk actually is. Relative risk and absolute risk are not the same thing. And breast cancer risk doesn't exist in isolation. Age, family history, genetics, breast density, alcohol consumption, obesity after menopause, physical activity, and other factors can all influence a woman's baseline risk. So when I'm talking with the women about hormone therapy, I don't want to ask only, does hormone therapy increase the breast cancer risk? I want to ask, what is your breast cancer risk? And how much might this particular treatment change it? That's much more useful conversation, right? But what if you have already had breast cancer? Well, this is a completely different situation. Systemic menopausal hormone therapy is generally not recommended for breast cancer survivors, particularly after hormone receptor positive breast cancer. There may be unusual circumstances in which treatment is considered, but those decisions require individualized shared decision making and typically collaboration with the patient's oncology team. And vaginal estrogen is a separate conversation from systemic hormone therapy. Low dose vaginal estrogen results in very little systemic absorption and has a different risk profile. So we shouldn't lump vaginal estrogen and systemic hormone therapy together. Who is generally a good candidate for hormone therapy? According to the Menopause Society, for most healthy women experiencing bothersome menopausal symptoms who are younger than 60 or within approximately 10 years of menopause onset, the benefit risk profile of hormone therapy is generally favorable. But hormone therapy needs to be individualized. Before prescribing it, we should be considering things like your personal history of breast or endometrial cancer, unexplained vaginal bleeding, cardiovascular history, history of blood clot or stroke, liver disease, age and time since menopause, family history and baseline breast cancer risk, and most importantly, the women's symptoms, goals, and preferences. There isn't one hormone prescription that's right for every woman. So take home message. Does hormone therapy cause breast cancer? The evidence doesn't support a simple yes or no answer. Estrogen alone and estrogen combined with the progestogen have different breast cancer outcomes. Duration matters. The type of progestogen matter. Your baseline risk matters. And your age and timing of treatment matter. Hormone therapy isn't risk-free, but fear shouldn't replace an evidence-based discussion either. For the right woman at the right time, hormone therapy can be very effective treating menopause symptoms. The goal isn't to convince every woman to take hormones. The goal is to give women accurate information so they can make an informed decision with knowledgeable healthcare professionals. That's what evidence-based menopause care should look like.